I'm Dr. Sarah Hurvitz, Professor of Medicine and Head of the Breast Cancer Clinical Trials Program at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. In 1987, it was discovered that a portion, around 25% of patients diagnosed with breast cancer will have breast cancer that is characterized by overexpression or amplification of HER2. This type of disease behaves more aggressively and is associated with a worse overall survival, which would have been a sad ending to the story had investigators not pursued the development of therapies that target HER2. The first of these was trastuzumab, which is an antibody that targets HER2. It is very effective in all stages of breast cancer. But since the original FDA approval of trastuzumab for metastatic HER2-positive breast cancer in 1998 and for early stage disease in around 2005, there's been the development and approval of 6 additional HER2-targeted therapies. There are currently 2 monoclonal antibodies available, trastuzumab and pertuzumab, 2 antibody-drug conjugates available where the antibody is linked to chemo to deliver the chemo specifically to the HER2 overexpressing cell, and those are TDM1 or trastuzumab emtansine, and the other one is TDXD or trastuzumab deruxtecan. And then we have now 3 tyrosine kinase inhibitors, which are small molecules, so they come in a pill format, patients can swallow them. And these are lapatinib, neratinib, and tucatinib most recently. In the neoadjuvant setting, meaning when a patient's being treated prior to surgery for non-metastatic or early stage disease, a standard regimen is to use trastuzumab and pertuzumab combined with chemotherapy. Patients who achieve a pathologic complete response, meaning no disease left at the time of surgery, go on and just complete the year of trastuzumab, and some will have that in combination with pertuzumab. However, for patients who don't have a pathologic complete response with that type of therapy prior to surgery, they are identified as having a high risk of disease recurrence, but we now know based on a trial called Catherine that if you give these patients the antibody-drug conjugate TDM1, trastuzumab emtansine, after surgery, you can significantly improve their chance of having cancer not come back in the next 3 years. And then the other agent that's available in the early stage setting is called neratinib. Neratinib is the small molecule pill form that targets the inside of the cell at the inside of the receptor of HER2 as well as other HER receptors. Neratinib was studied in a trial called Extenet and shown that when given for a year after completing the 1 year of trastuzumab, it reduces the risk of breast cancer coming back, especially in hormone receptor positive HER2 positive disease. Finally, in addition to those 4 agents which are available for early stage disease, we have the availability of additional therapies for metastatic breast cancer, and these include trastuzumab deruxtecan, which is a new antibody-drug conjugate, very powerful, and that is available for patients whose disease has already progressed on trastuzumab and TDM1, and a new molecule called tucatinib, which is like neratinib, but it's selective for HER2. So it has fewer side effects, fewer issues like diarrhea associated with it. And one of the great things about it is it penetrates that blood-brain barrier and has activity in patients with brain metastases from breast cancer. And then finally, we also can use neratinib in this setting. So it's a very exciting time to be able to treat patients with HER2-positive disease because we're now seeing the overall survival outcomes improve regardless of stage at diagnosis with the use of HER2 selective therapies.